Bonjour à tous. Nous sommes ici ce matin avec la Dr Tam, le Dr Njoo. Ils donneront des mises à jour et le Dr Wong et moi-même. Sans plus tarder, nous commencerons avec la mise à jour, d'abord en anglais avec la Dr Tam, suivi par le Dr Njoo en français et enfin moi-même. Merci.
Merci and bonne journée. I will start with the latest numbers on COVID-19 in Canada. There are now 66,730 confirmed cases, including 4,628 deaths. And 30,600, or 46%, have now recovered. Labs across Canada have tested over 1,067,000 people for COVID-19 to date, with about 6% of these testing positive. In the past week, we've tested, on average, 26,000 people daily. Today, I want to focus on the disproportionate impacts and severe outcomes of COVID-19 on our seniors. It's hard to calculate the hardships endured and the grief that remains for those we've lost. Canada's older adults are the keepers of our history, culture, and wisdom. Each loss is one too many, but the scale and impact on our seniors as a whole is nothing short of a national tragedy. Prevention and control of COVID-19 in high-risk populations is crucial for controlling this and future waves of COVID-19. These outbreaks drive up the case fatality rate, accelerate spread, and continue to spill over into the community. But it is our older adults who bear the brunt. Though an estimated 20% of COVID-19 cases in Canada are linked to long-term care homes, over 80% of all deaths are among seniors residing in these settings. A range of measures has been implemented in an effort to prevent the introduction and spread of COVID-19 in long-term care homes. However, many areas of the country are still struggling to get ahead of the rapid and stealthy spread of the virus in these outbreaks. We know that where there are weaknesses, whether structural, social, or economic in nature, this virus will take advantage. If we are willing to give what it takes to address these weaknesses in long-term care and assisted living homes and to provide better support to poorly compensated workers in these settings, we stand a better chance of maintaining control of the virus. We will be living with COVID-19 for some time. If we make it a priority to look after the most vulnerable in our society, we can change the outcome of this pandemic and not live in its shadow. Together, we can do this. Thank you.
Merci, Dr Tam. Dr Njoo.
OK, merci. Bonjour. Comme d'habitude, je commencerai par énoncer les plus récents chiffres à propos de la COVID-19 au Canada. Il y a maintenant 66 780 cas confirmés, dont 4 628 décès et 30 600 personnes, soit 46 %, qui sont maintenant guéris. Les laboratoires de partout au Canada ont fait des tests de dépistage de la COVID-19 chez 1 067 000 personnes jusqu'à maintenant, dont environ 6 % ont reçu un résultat positif. Au cours de la dernière semaine, nous avons testé en moyenne de 26 000 personnes par jour. On tient aujourd'hui à mettre l'accent sur l'incidence disproportionnée et des résultats graves de la COVID-19 chez nos aînés. Il est difficile de connaître les épreuves subies et le chagrin éprouvé pour les personnes que nous avons perdues. Les aînés du Canada sont les gardiens de notre histoire, de notre culture et de notre sagesse. Chaque perte en est une de trop. Mais la portée de la COVID-19 et son incidence chez nos aînés ne sont rien de moins qu'une tragédie nationale. La prévention de la COVID-19 et la lutte contre cette maladie au sein des populations à haut risque sont essentielles pour maîtriser la présente vague de COVID-19 et les prochaines. Ces éclosions font monter le taux de mortalité, accélèrent la transmission et continuent de se produire dans la collectivité. Mais ce sont nos aînés qui sont le plus durement frappés. Même si l'on estime que 20 % des cas de COVID-19 au Canada sont associés aux établissements de soins de longue durée, plus de 80 % des décès touchent des aînés résidents dans ces établissements. Une gamme de mesures a été mise en œuvre en vue de prévenir l'introduction et la transmission de la COVID-19 dans les maisons de soins de longue durée. De nombreuses régions du pays font encore des pieds et des mains pour prendre le dessus sur la propagation rapide et furtive du virus dans ses éclosions. Nous savons que là où il y a des lacunes, que ce soit du point de vue structurel, social ou économique, il y aura introduction du virus. Si nous avons la volonté de faire ce qu'il faut pour remédier à ces lacunes dans les établissements de soins de longue durée et les résidences d'aide à la vie autonome et d'offrir de meilleures mesures de soutien au personnel mal rémunéré qui travaille dans ces établissements, nous aurons plus de chances de maîtriser le virus. Nous devrons vivre avec la COVID-19 pour un certain temps. Si nous nous fixons comme priorité de nous occuper des personnes les plus vulnérables de notre société, nous pouvons changer l'issue de cette pandémie et ne plus subir ses répercussions. Ensemble, nous le pouvons. Merci.
Merci, Dr. Njoo. Kwe Tanse Ulukut, good afternoon, bonjour. Although nearly 8 weeks have passed, the public health measures that we've been repeating from these seats and that you have heard so many times over have not lost their importance. They are just as important as on day one. As of May 8th, we've seen 165 confirmed cases of COVID-19 in First Nations communities on reserve and 16 cases in Nunavik in northern Quebec. I would ask everyone to remember that number as I continue with this update. This week, we saw a rise in cases within remote communities of northern Saskatchewan. We're concerned by this, and we are working with local leadership to support these communities in their response. Some communities heavily impacted around the La Loche area include First Nations Reserve, but not only. This is why we need to keep collaborating with the province of Saskatchewan to ensure the medical staff and leadership in the area can get the support they need to respond to this outbreak. The situation demonstrates that the onset of COVID in some Indigenous communities may have been being delayed by remoteness. We need to remain vigilant. And we need to do more to provide the resources to make sure that the people that are suffering from this in and around the La Loche area and in La Loche are properly served. This is what we've been working on. Across the country, we continue to work in close collaboration with Indigenous communities to secure the necessary resources to combat the spread of COVID-19, including with the Meadow Lake Tribal Council, the communities of Clearwater River Dene Nation and English River Nation, and the Métis Nation of Saskatchewan. For example, in northern Saskatchewan, all frontline health services are delivered by First Nations and tribal councils with public health oversight by Northern Intertribal Health Authority. Together, we are monitoring the inventories of personal protective equipment, or PPE, in this region. As of May 8th, we have sent 129 PPE shipments to First Nations communities in Saskatchewan, including 59 PPE shipments sent directly to the Northern Intertribal Health Agency. The Métis Nation of Saskatchewan, as well, has utilized resources through the Indigenous Community Support Fund to support their community members with a focus on elders, food security, and PPE. We're also providing direct nursing services to 19 Saskatchewan First Nations communities and are providing support such as nursing recruitment and health services coordination to 25 communities. Overall, there are 70 Indigenous Services Canada nurses in Saskatchewan offering services to all 74 First Nations communities in Saskatchewan. I'd like to sincerely thank them for tirelessly working on the front line of this outbreak and putting their own safety at risk. But numbers don't tell the whole story. First Nations, Inuit, and Métis communities have done an incredible job in responding and preventing outbreaks. Their collective work in this is critical, and our commitment to support them and making sure they have what they need and are able to continue to protect their community members remains steadfast. Pour appuyer les leaders autochtones et nos partenaires à répondre efficacement à la pandémie et à protéger leur population, nous avons annoncé un fonds de soutien aux communautés autochtones basé sur des distinctions de 305 millions de dollars afin de répondre aux besoins immédiats des communautés des Premières Nations, Inuits et Métis face à la COVID-19. Bien que la majorité de ces fonds aient été directement transférés aux communautés, 15 millions de ces dollars ont été alloués à des organisations autochtones urbaines et hors réserve. En plus du soutien, de ce soutien aux communautés autochtones, nous avons annoncé d'autres mesures supplémentaires afin de soutenir les plus vulnérables à traverser cette période difficile. Nous avons annoncé donc 10 millions de dollars pour les refuges pour la prévention de la violence familiale dans les réserves et au Yukon afin de soutenir les femmes et enfants qui fuient la violence. 306,8 millions de dollars de financement pour aider les petites et moyennes entreprises autochtones et pour soutenir les institutions financières autochtones qui offrent du financement aux entreprises. 75,2 millions de dollars pour les étudiants des Premières Nations, Inuits et Métis de niveau postsecondaire pour l'année 2020 et 2021. 129,9 millions de dollars pour répondre aux besoins immédiats en matière de santé, d'économie et de transport dans le Nord. Nous savons que davantage d'aide sera nécessaire et nous travaillons activement à veiller à ce qu'aucune communauté autochtone ne soit laissée pour compte. As we are learning from past experience with responding to pandemics in Canada and specifically in First Nations, Inuit, and Métis communities during H1N1, we need to recognize and understand that they have a higher risk of being disproportionately impacted by COVID-19. Along with better access to testing, we are acutely aware of the need to do better, more robust, and routinely collected disaggregated data. As my colleague, Minister Bennett, says, you can't mend what you don't measure. And to be frank, the data that my department provides is limited by what it's being collected. This means accurate data is only available for First Nations living on reserve and for Inuit living in Inuit Nunangat. I ask people to remember the number that I gave at the outset, and if you look at the numbers in the far north in La Loche, the number of positive cases is at about 170 plus. Of that, there are 16 on-reserve Indigenous positive cases. But given that La Loche is a Métis Dene community of an overwhelming majority, the presumption then is that the entire 179 cases or so are Indigenous. And that's a gap in the data, frankly. When Indigenous leaders, and I would add, I would pause to say, when you put that in an urban context such as Montreal or Toronto or Vancouver or Calgary or Winnipeg, that data is just not there. When Indigenous leaders and organizations are calling for better data to be collected and disseminated to them, we need to make sure they have that data. It needs to include data for Inuit outside Inuit Nunangat, among citizens of the Métis Nation or First Nations people living off their reserves, and for this to be realized, we need help from provincial governments and public health agencies. This type of information is critical not only for Indigenous communities, but for many vulnerable groups. We need to be able to put forward tailored measures to prevent any further outbreaks, as well as to expand and improve effective interventions if they occur. Indigenous-led analysis of this information is necessary to advancing culturally appropriate and science-based approaches, both with on and off reserve for First Nations and with Inuit and Métis communities. Indigenous Services Canada is playing a key role in collaboration with First Nations, Inuit, and Métis partners, the Public Health Agency of Canada, and the provinces and territories to support ongoing surveillance of COVID-19 positive cases for on-reserve communities. However, this data, as I mentioned, is not enough to provide us with an accurate overview of the impact of the virus in First Nations living off reserve, as well as in Inuit and Métis communities. This is why I'm pleased today to speak to the work of Dr. Janet Smiley, a Métis research scientist and physician at the Centre of Urban Health Solutions at St. Michael's Hospital in Toronto. She's currently working, along with many other partners, to collect the necessary data that will allow for better understanding and modeling of COVID-19 cases in Indigenous populations in Canada. As part of the efforts and our efforts to support better distinctions-based data collection, we're providing $250,000 to this critical initiative to implement a COVID-19 tracking and response platforms for First Nations, Inuit, and Métis. This project will include the development of a COVID-19 consortium comprised of federal, provincial, territorial, First Nations, Inuit, and Métis partners, and their data analysis will help inform the response to COVID-19 by Indigenous communities with the support from the federal government. In the short term, we hope that our work will help mitigate the adverse and disproportionate impacts of COVID-19 on First Nations, Inuit, and Métis. They are leading the way in addressing this data gap, and I applaud them in this work and effort and look forward to the additional initiatives in this space. As I've highlighted before, on another topic, remote and fly-in First Nations communities are vulnerable during this time. The ongoing delivery of essential services, medical care, foremost, and supplies to these communities in a time when travel is limited is particularly challenging, but critical to Canada's overall response to COVID-19. To minimize the risk and exposure of the virus to community members and service providers alike, we are transporting essential service personnel and supplies via carefully managed flights that adhere to strict health safety measures on airlines that already serve these communities. The first flights of this nature took place on April 22nd. That day, 45 nursing professionals were flown to and from 23 First Nations communities in flying communities in Manitoba and Ontario. On April 27th, another 22 nursing professionals were flown to 13 First Nations communities, and 18 left the communities on their return charter flights. These charters ensure that healthcare and infrastructure professionals, medical supplies, and equipment required to maintain critical infrastructure such as water treatment plants will be able to access these communities. It also provides flexibility to support other community needs such as emergency management responses, food security, or medevac services. In addition to maintaining critical services, this approach also provides a much-needed revenue stream to airlines serving Indigenous communities, helping to support their economic long-term and short-term viability. As we face unprecedented times, nurses working in Indigenous communities continue to demonstrate their selfless dedication to ensure the highest quality of culturally appropriate care, testing, and treatment. Once again, I want to thank the First Nations, Inuit, and Métis nurses practicing in various settings in Canada, caring for patients while working to promote and provide culturally safe healthcare. Bien que les chiffres à travers le Canada soient dans l'ensemble positifs, je tiens à répéter que nous devons tous suivre les directives et conseils de santé publique, tels que maintenir la distance physique, se laver les mains et éviter les grands rassemblements. Ces efforts continuent d'être essentiels pour ralentir la propagation du COVID-19 au sein des communautés et entre personnes. Notre objectif est de continuer à travailler en partenariat avec les Premières Nations, les Inuits et les Métis, et à mesure que les provinces, les territoires et les villes commenceront à discuter de l'assouplissement éventuel des restrictions, nous continuerons d'être extrêmement vigilants et de défendre le point de vue et la position unique dans laquelle se trouvent les communautés des Premières Nations, Inuits et Métis. Je reste encouragé par les mesures prises par les leaders autochtones à travers le pays et je demande à tout le monde de rester vigilant alors que nous travaillons ensemble pour que tous demeurent en santé et en sécurité. Miigwech, Nakumik, Marcy, thank you, merci. Maintenant, on est impatient de prendre des questions. Carl?
Thank you, Minister. So we'll start on the phone with 3 questions. 1 question, 1 follow-up, et on va venir dans la salle par la suite. Operator?
Thank you. The first question is from Michel Lamarche from TVA Nouvelles. La première question de Michel Lamarche de TVA Nouvelles. À vous la parole.
Oui, bonjour. Peut-être une première question pour le Dr Tam et le Dr Njoo. J'aimerais vous entendre sur cette situation qui perdure dans les centres de soins de longue durée. Vous parlez ce matin d'une tragédie nationale, carrément. Est-ce que vous êtes perplexe devant le fait que ça soit toujours aussi problématique dans plusieurs de ces centres de soins de longue durée où les autorités semblent pas du tout avoir pris le contrôle de la situation?
Oui, merci pour la question. C'est Dr. Njoo. C'est sûr, c'est une tragédie nationale à travers le pays parce qu'on voit partout dans toutes les provinces et territoires que il y a des éclosions actuellement dans les établissements de soins de longue durée. Et c'est aussi un problème au Québec. Qu'est-ce qui se passe? On sait qu'il y a des défis, même structurels, parce que dans les établissements, des fois, dans les chambres, il y a 2, 3, 4 personnes peut-être, et c'est difficile de séparer les personnes qui sont malades des autres qui ne sont pas touchés ou contaminés avec le virus. Mais on sait que les autorités sanitaires sur le terrain font leur mieux pour dépister, pour isoler, pour aussi traiter les personnes peut-être envoyées aux hôpitaux comme nécessaire. Et c'est vraiment une leçon, je pense, appris pour tout le monde, à toutes les échelles du gouvernement, que il faut faire mieux. Il faut peut-être après cette pandémie, avoir, comme on dit, une enquête pour voir comment on traite nos aînés, comment on les supporte, comment on les je ne sais pas quoi dire, même en anglais ou français, qu'est-ce qu'on peut faire pour faire mieux pour les résidences et les établissements de soins de longue durée aussi, comme Dr. Tam et moi on dit, même aussi pour le personnel, parce que c'est pas seulement une question des résidents, c'est aussi comme tout le personnel qui font un bon travail maintenant, ce qu'ils peuvent faire avec les conditions vraiment très dures. Et on n'a pas, comme dit, peut-être des solutions, réponses tout de suite, mais comme on dit, on voit qu'est-ce qui se passe actuellement et au fur et à mesure, on fait nos meilleurs efforts et on voit peut-être qu'on a peut-être maintenant on peut voir peut-être un peu de la lumière au fond de la tunnel. Merci. What's happening in sort of long-term care establishments across the country, as Dr. Tam and I've said, really is a national tragedy. Many of the issues or challenges in long-term care facilities, I think, are evident. There's even structural ones in terms of, sometimes there are 2, 3, 4 individuals in a room. It's difficult to separate a cohort, sick people from the well people. There's also challenges, as we all appreciate, in terms of the personnel who are doing their best, obviously working in these facilities that obviously, as we know, may not have the supports they need, as we talked about, the pay, the fact they sometimes have to work between several facilities. So there's lots that we need to learn from what's happening. Certainly, I think after all this is done, I think even as our minister has said, that there needs to be, I think, a national conversation about how we treat our elders, how we house them, take care of them in their later years. So that's something that needs to be done. But certainly at the present time, everyone's doing their best. And I think we are starting to see a bit of, I guess, a light at the end of the tunnel. I would just say, as our minister said, I think we need a national conversation. What the form is not for me to say. I think it's a conversation at different levels of government. I think also different sectors. I think it's a conversation beyond public health. I'm sticking to, as they say, the public health aspects. We certainly show from the epidemiology that older individuals, obviously those in long-term care facilities, are at a particular risk in terms of having, as they say, more severe consequences, obviously including death, if they do become infected with this virus. But then how that translates in terms of the conversations that many other sectors and levels of government need to have to help manage and hopefully prevent and not have this type of situation occur should there be another second wave or even a future pandemic of another virus. Yes, that needs to happen. Thank you.
Michel, en suivi.
Bien sûr, peut-être une seconde question pour le ministre Miller. J'aimerais vous entendre, Monsieur le ministre, en votre qualité de député de la région de Montréal. Est-ce que vous partagez les inquiétudes du premier ministre? C'est ce qu'il a dit ce matin là, devant le déconfinement à Montréal et ces éclosions là, dans certaines communautés. Est-ce que si on ne veut pas risquer la sécurité, la santé des populations les plus vulnérables, il ne faut pas mettre la pédale douce sur ce déconfinement dans la grande région de Montréal?
Merci, Michel. Je dirais ceci absolument. Je suis le député du centre-ville de Montréal où c'est l'hécatombe dans les centres de soins de longue durée. L'armée y est déployée. Nous avons fait des efforts surhumains et on a demandé aux Québécois, aux Canadiens de déployer des efforts surhumains pour se confiner, pour prendre des mesures qui ne sont pas nécessairement prêts à faire dans des circonstances normales. Et un déconfinement hâtif pourrait mettre en danger la vie des gens. Évidemment, j'ai des parents qui habitent au centre-ville de Montréal. Mon père fête 80 ans cette année, en fin mai. C'est une personne très susceptible, très vulnérable. Ma mère aussi, qui a 76 ans. C'est personnel, mais c'est aussi scientifique de par la nature. Les gens sont confinés. On voit ce qui se passe dans les centres d'aînés. C'est les gens les plus vulnérables qui sont dans ces centres parce qu'ils sont vulnérables, ils veulent passer la fin de leur jour en toute dignité et ces gens meurent en toute indignité. Donc, il y a du chemin à faire. Il y a des réflexions de longue durée à faire aussi en sortant de cette crise, de cette pandémie. Mais le constat scientifique qui se fait, c'est qu'on n'est pas sorti du bois et ça prend un petit effort de plus de la part de tous les Canadiens pour s'assurer qu'on n'a pas une deuxième vague, une troisième vague qui vienne nous frapper de plein fouet. C'est mon constat. Look, I'm an MP from downtown Montreal, and that is where, along with a number of other MPs that are in our caucus and cabinet, the pandemic is hitting, and it is at its worst. The people that are dying are, the vast majority, as Dr. Tam said, very old. They have spent and been put into long-term care facilities to spend the rest of their days in dignity, and they're dying in indignity in vast numbers. And that will continue if there are measures that are relaxed too soon. That is the scientific conclusion. The Army is working as best it can. People that are willing to put their lives at risk. That's why they join the armed forces, and they are doing something that they are not used to doing, and they are doing it with exceptional professionalism. And we need to let them do their work. We need to let the virus run its course with all the measures that we put in place, and we've asked Canadians to do that they're not used to doing. And so to relax measures in a premature fashion would just raise another question about another wave or a third wave that would come hit us harder than it should if we were to continue along the lines and according to all the sacrifices we've asked people to make and all the hit that it's had on the economy. So the issue is really to come out stronger and strong and not worrying about a second wave or additional shutdown measures. And we're asking people to do and to be a little more patient. We're not out of the woods. And if you ask any of our top scientific minds, I think they would agree.
Thank you, Minister. Operator, next question, please.
Thank you. Merci. La prochaine question de Theresa Wright de la Canadian Press. The next question from Theresa Wright from the Canadian Press. Please go ahead.
Yes, good morning. I have a question about masks. I'll pose it to Dr. Tam, but perhaps Minister Miller, you could also weigh in as it has to do with procurement. Earlier this week, the Chinese embassy said the 1 million N95 masks that were rejected by Canada last month were the result of a contractual issue. We still haven't been given a clear answer about what happened there. Now there are 8 million more masks that have been rejected. Can you give a clear answer about why Canada is rejecting these masks and whether we're still planning to purchase further supplies from these companies?
It's Theresa Tam here. I'll just start from the perspective of the agency. We conduct the testing, basically. So that's where we found that a significant proportion of these masks did not meet our standards. So, and just to say that none of them have been distributed for medical use. So that is sort of our key responsibility. And I know that the teams are working on the contracts, of course, and the supplies are looking at this very carefully. I don't personally know what the contractual issue is that someone has cited, but I think our job is to make sure that whatever goes out, it meets a certain standard. And of course, when this much product does not meet standard, you have to go back and look at that arrangement.
Well, I think that's right, Theresa. I think what you've seen publicly is concerns over a number of issues that among other, Mr. Anand has mentioned, which is, in one case, whether the straps were adequate. There's perhaps concerns over the quality of the filtration, whether these masks can be repurposed. When you're working in real time trying to prevent the onset of a pandemic, you make decisions. You make decisions quickly, and the real challenge is to adjust in real time when you recognize that you may not have a source quality that works. and to move on. But as Dr. Tam said, we test vigorously. I think that's something people should be glad for, frankly, as opposed to just deploying them into the public health system and encountering a lot of other headaches. So recognizing that, it's very possible. And I'm not part of these discussions. I would direct those questions, frankly, to Minister Anand. So I don't know the contractual terms in between the parties, and I can't speak to that. But recognizing that what Dr. Tam said is that we are testing and we are not deploying things that we believe are unsafe for the purposes that they were purchased for, and that's an important conclusion.
Theresa, follow-up?
Yes, thank you. Just on some of the comments that you mentioned in your opening remarks, Minister Miller, about a gap in data that's not allowing us to get a full picture of how COVID-19 is affecting Indigenous populations. As you said in your remarks, a lot of this is because the data is held by provinces and territories. What measures can the federal government take to try to perhaps compel provinces and territories to provide this data? And how confident are you that they actually have the data or capturing this data as the pandemic has been spreading?
Well, that's two separate and very important considerations, Theresa. First, if the provinces and territories have the data, that's the easy part. And it's a question of really coordinating. And because we are moving at the rate that we are moving, it's a question of gathering that and collating it and comparing it. And having our top scientific minds work on it and draw conclusions for really two purposes. The first purpose is, as everyone knows, we've put forward some very rough approaches to trying to contain the pandemic, asking people to isolate, clamping down, asking people to quarantine, and that data is important across sectors and not just with respect to Indigenous populations, but race-based data, ethno-cultural data that's being collected, and it allows you in the short term to be able to take measures that are more targeted, whether you surround old age homes, if you have age-based data, if you have certain communities that are vulnerable for whatever reasons, you can target your response as you try to address a pandemic before you get the vaccine. And the second measure, and it is an equally important measure in the long term, is you can't do good public health policy without the data to underpin it. And in order to do that, you need to have accurate data at the source. You can tease this together, and a lot of scientific modeling has a lot of projections and assumptions in it, but it is always based on a core set of assumptions based on important data collection. And so what we have is across the jurisdictions, all the provinces and the territories, that when they test someone have a different sheet with a different set of pieces of information. Now, assuming that those sheets have disaggregated data identifiers to begin with, we need people on the ground filling them out and then collecting them as they try to prevent people from getting infected. So it's a lot on frontline workers to ask them to do, but the importance that I'm trying to get out and we're trying to get out as a team is we need that data to be able to get real accurate information with respect to communities, get it out so that people know what the measures can be taken to address COVID-19 and how it's profiling, and then give accurate models. The other consideration, which is a very important consideration with respect to Indigenous communities, is Indigenous control over Indigenous data. Layered onto that is a sub-concern dealing with private patient confidentiality we have to respect. The worst thing that could happen is to create another set of stigmas that would fly around, and people would judge people for no particular reason. But that data is important to collect, and we do have to be sensitive to First Nations control over First Nations data. But the premise to that is that we have to be collecting it in the first place. And while Indigenous Services Canada, for its part, is able to tease out the amount of people that are testing positive in communities on reserve or in the far north. When it comes to particular population, which half the Indigenous population of Canada is off reserve, quote unquote, mostly in the main urban centres. And that really is the responsibility of the testing protocols of the province. And that data is either not collected or imperfect in its collection basis. And that's why we've teamed up with the folks at the University of Toronto at St. Michael's to make sure that we have a center focal point with people that know what they're doing so that we can get a better sense of modeling. But I will hide from no one the fact that on the ground, the testing and the collection of that data right now is far from perfect.
Thank you, Minister. Operator, next question, please.
The next question. The next question is from Althea Raj from Huffington Post. La prochaine question d'Althea Raj de Huffington Post.
Hello. I'm hoping you can hear me. Yeah. Okay. Great. My question is for Dr. Tam and Dr. Njoo. I guess I'm going to try this again from yesterday. You said that we need to test more. Yesterday, you said that you're not hearing anything specific about the provinces and the territories not having enough swabs or reagents. So, what do we need to do to increase testing?
So I think, as I said yesterday, there's a capacity, but we, as a public health community, the chief medical officers feel that you have to test for the right reasons at the right place. So just upping the numbers isn't necessarily the approach. But all of them, let's just say, are expanding their testing to include people with a whole range of symptoms. That's one way of trying to widen your net to see if there's any further cases in the community, for example. You will see that many jurisdictions are now doing quite a lot of they're essentially being very low threshold in testing high-risk settings. So if it's a long-term care facility, if it's a correctional facility, if you've got an inkling that anyone is sick, test them, but also if there's a case to rapidly enhance testing under all of those high-risk conditions is a good strategy. The other thing is that it depends on the epidemiology. And so epidemiology is changing in Canada, and those numbers will go up and down as a result. Yesterday, you may have seen that in Quebec, in the area most affected, they are increasing the testing by mobilizing clinics to go into the hotspots. And that is how they are increasing their numbers. And also, Ontario, for example, is doing a systematic testing of their long-term care facilities. So those are sort of in alignment with where these outbreaks and cases are occurring, but also to widen the net in the community setting. There's also been sort of surveillance approaches, and we will be examining more of these strategies as we move into the next phase with the Chief Medical Officer of Health, but also our public health laboratory networks. So the guidance, for example, in the next phase is under discussion at the Special Advisory Committee as to where else would you need to test more. But you can't just sort of indiscriminately test areas where there are no cases and for which people have no symptoms. So otherwise, you, again, get into these issues of test interpretation. But it is an area that we're very seized with and how we do expand into that. The other concept is surge capacity, because there may be other waves, and they may be waves into the future. We all got to sort of prepare for it by upping the capacity itself. If you expend a lot of tests, reagents, swabs, whatever now in areas where there's probably not needed, you're then diminishing that capacity for when you actually need it. So this is a complex discussion where we all agree that even with 60,000, that's a good capacity, but we're not stopping increasing our supplies, resources, etc., to even beyond that, because you got to sort of prepare for resurgences, etc. But each jurisdiction may have their own reasons as to why they haven't. They've all set different targets, and their abilities and their reasons for not yet reaching those targets, for example, is diverse, I would say.
It's Dr. Yu. Maybe I can just expand a little bit on what Dr. Tam has been saying. I think it's important to clarify when we've been talking about this sort of 60,000 tests. That speaks to, I think, from what I understand, the laboratory capacity. So the ability of, quote, the laboratories across the country to actually, quote, process the samples. But as we all know, there's, of course, a lot of steps in between in terms of actually, quote, getting the samples from the patients who need to be tested and then getting to the laboratory so then they can do the analysis. So what we're seeing sometimes, for example, that the case in the city of Montreal is that it's not just a question of having the laboratory capacity to analyze, analyzed, but it's also having, quote, accessibility for the people who need to be tested to then, quote, get the samples taken as appropriate to then be sent to the laboratory. So in that regard, I certainly we're seeing, for example, in the city of Montreal, good steps in terms of increasing accessibility with sort of mobile sites, et cetera, so that the patients, it's actually closer and easier for the people who need to be tested to get tested. So that's one of the things that we're seeing on the ground that obviously is getting better and better. Thank you.
We'll see a follow-up.
Okay. We're getting, closer to the answer I was looking for yesterday. But so I appreciate that you're explaining to us what we need to do to expand capacity in terms of like who we should be testing. But, you know, when you talk about accessibility, can you outline those reasons? Dr. Tam, you said there are many reasons. Like, practically speaking, how could the provinces be testing more? What needs to be done to increase testing practically?
So I think that depends on the jurisdiction themselves. So a lot of the provinces that have had no cases, they've had no transmission, they're in a very different situation than some of the larger provinces who do have cases and are still dealing with some community transmission. So it depends on where you're talking about. It does have to be tailored to the individual setting. Some areas might actually have human resource issues. You need actual people to go out to test cases. So making sure you have the necessary trained people who can do the testing is one. Dr. Njoo talked about accessibility, maybe making those testing clinics closer to where people are. We talked about the deployment of certain more closer to patient tests, like point-of-care testing, to the more remote communities. That's another area where we can, increase capacity as well, so that people don't have that sort of turnaround time. In Saskatchewan, for example, that was a good sort of example of how they are now systematically looking at those communities where there have been cases in the north. And that involved the deployment, which they have now access to, some of the sort of point-of-care testing capacity. And so there are a number of these, I guess, challenges that each jurisdiction has to undergo from, as Dr. Njoo said, the moment that the patient needs to be tested all the way down to transportation and, laboratory testing capabilities. And a lot of the strategies are designed to tackle each one of these components. But it might quite well be different in downtown Montreal to downtown Toronto to Saskatchewan.
Thank you, Doctor. We'll now turn to the room, starting with Christian Noël de Radio-Canada.
Bonjour. Une question pour M. Miller et pour Dr. Tam et M. Njoo aussi, Dr. Njoo aussi. M. Miller, vous avez dit à propos du Québec, de Montréal, on n'est pas sorti du bois. Peut-être qu'on va trop vite. Est-ce que vous pouvez préciser votre inquiétude pour les gens et aussi pour ce que ça veut dire pour la suite des choses si on va trop vite? Et pour M. Dr. Njoo, Dr. Tam, partagez-vous cette inquiétude et celle de l'Institut national de santé publique du Québec qui dit que si on déconfine trop rapidement, ça va probablement mener à plus de décès et plus de morts. Merci.
J'ai peur qu'il y ait plus de gens qui meurent. Premier point. J'ai peur d'une deuxième éclosion, une plus grande éclosion.
Oui, merci, c'est Dr. Njoo. Oui, on continue toujours avec nos discussions. On a de bonnes communications avec nos homologues de Québec. Et c'est sûr à Montréal que c'est une situation, on peut dire, plus grave que peut-être le reste du Québec. Ça, c'est sûr. Et je pense que c'est très, très complexe. On dit qu'on a une situation actuellement qui est très, très dure dans les établissements de soins de longue durée. Mais c'est un peu lié avec ce qui se passe aussi dans les hôpitaux de Montréal. Parce qu'avant, avec les aînés, peut-être quand ils étaient contaminés, infectés, très malades, on a transféré comme patients aux hôpitaux. Mais avec ce qui se passe actuellement dans les établissements encore, peut-être avec les éclosions, peut-être ce n'est pas une bonne idée de les transférer après encore aux établissements de soins de longue durée. Donc, ils restent aux hôpitaux et ils sont dans les lits, pas beaucoup de marge de manœuvre, la capacité des hôpitaux. Si on attend peut-être une deuxième vague, troisième vague, donc il faut vraiment examiner et regarder étroitement la situation à Montréal avec un système de surveillance très étroit aussi bien dépisté. Parce que si on commence à assouplir les mesures de santé publique, il faut être très prêt pour peut-être ajuster au fur et à mesure si la situation change. Et je pense que c'est la situation à Montréal. Moi, je ne suis pas sur le terrain, mais je vois qu'est-ce que les autorités sanitaires de Québec font maintenant. Il y a peut-être un horaire, quelque chose pour le Québec, mais c'est un peu différent pour Montréal, pour les écoles, les magasins. Et c'est parce qu'on sait que les situations sont un peu différentes à Montréal comparées du reste du Québec. Merci. In English, where was I start? The situation in Montreal, it's obviously everyone recognizes it's serious and it is complex. For example, because of the situation that we know is a problem in the long-term care facilities. Perhaps several weeks ago, obviously there were patients there, residents who were sick, ill, and then were transferred to hospitals in Montreal. But now, with the ongoing situation in those facilities, it's not appropriate to be, quote, transferring these patients back, and therefore, obviously, they're taking up beds in the hospitals. In the hospitals in Montreal, there's not largely say excess capacity or sorry, you call it, surge capacity in case there might be a second wave or sort of another uptick in cases. So that's why the authorities in Montreal are watching the situation carefully. It's for sure important that you need to have a very good surveillance system, testing system. So as the measures of this slight relaxation of the public health measures are taking place, and maybe there might be opening of schools or businesses, that you have to be ready to be able to detect rapidly, deal with the situation, and then maybe adjust as it goes along.
And this one is for Dr. Tam and maybe Dr. Njoo as well. But Dr. Tam, I'd like to hear you first on this. If Quebec is one of the hardest hit area, Montreal as well, and they seem to be proceeding maybe early, maybe quicker than other area. Cases seems to be still increasing. Testing is not up to par. Do you feel Montreal and Quebec is following the federal guidelines right now for deconfining, and what would you suggest they do?
Well, I think from all the chief medical officers, we laid down the sort of criteria for relaxing, if you like, the public health measures, which includes the testing, the ability to do case and contact tracing, isolation, quarantine, etc., and making sure there's capacity. So all this is being evaluated by the jurisdiction every day. They may or may not change the target date according to the situation, and I think that's what they're trying to do every day. And so there has to be flexibility, and that, I think that is very clear to our colleagues that the Montreal area is different to other areas of Quebec. And they're being cautious, so some of these measures are done outside of that area. They've moved these mobile clinics into certain hotspots to get some more testing. So they are going to try to be very, very careful about this, and they have to evaluate this probably on a daily basis in terms of what's going to happen.
Pardon? Non, on n'a pas dit ça. C'est Dr. Njoo. Je pense que les autorités sanitaires de Québec, pas seulement de Québec, de Montréal, parce que c'est vraiment les autorités sanitaires de Montréal, ils examinent, analysent la situation au fur et à mesure. Et les principes aussi, on a discuté au sein de la comité consultatif spécial. Il faut regarder aussi les principes, tous les principes des mesures même préventives à l'échelle individuelle, de se laver les mains souvent, de garder une distanciation physique de 2 mètres comme possible. Tout ça, ça reste reste en vigueur. Donc, je vois même à Montréal, je pense que le transport en commun, on a fait une forte recommandation de peut-être porter des masques non médicaux si on utilise le transport en commun. Donc, je vois que les autorités sanitaires de Montréal prennent pour sérieux toutes les recommandations de santé publique et ils ont, comme dit, adapté pour leur contexte à Montréal. Merci.
Thank you, Doctor. Ashley?
Good afternoon, Ashley Burke, CBC News. Dr. Njoo talked about having a national conversation around long-term care after this is all said and done because it is a national tragedy. Minister Miller and Dr. Tam, do you think that's a good idea? Should there be a public inquiry into long-term care homes after this?
Look, Ashley, I think as I'd mentioned earlier, what we're seeing is that really the older segments of the population, those in long-term care facilities, are being, by a vast proportion, heavily impacted by this. It's a question, as a human being, I think everyone is asking ourselves how we treat, in some cases, our grandparents and our elder segments of the population. What form that takes. Without any question, I think everyone's going to be asking themselves that. I think there needs to be some serious look into the way that is done on an institutional basis. It's probably premature to speculate as to what form that lesson takes. I think that is probably the smaller consideration to the bigger reflection we all need to have as to how we finance, resource, help those people that are the most vulnerable. In this case, perhaps the greatest generation that are the reason why we live in a free and democratic country. It is scary to see people fall like that. And when you talk about Indigenous communities in particular, you're seeing some people that are last carriers of their language, and you can see entire languages disappear. So those are particular vulnerabilities that I see in my files. I think Tom sees them as well, and that risk is top of mind when we look at Indigenous communities. When we look at Canada writ large, we need to be asking ourselves those serious questions, and there needs to be serious discussions around financing, around funds, around support, around even how we ourselves treat some our own grandparents. Some of the stories coming out of those long-term care facilities, you see people that are looking for refugee status that are helping out. You see first-generation Canadians. You see people that are working for low-paying jobs. That's another reflection I think we all need to have. But that needs to be institutionalized in a form, and I think that is secondary to the greater consideration, which is how we treat our elders. Dr. Tam, if you want to add.
Yeah, and again, I'm not going to speculate the format at which that takes place, but it is really critical that, out of all the impacts of this pandemic, we've got to learn something in a huge way about how we treat as individuals, society, communities, governments on our older adults, and in particular, those who reside in long-term care homes and assisted living, but maybe other areas where seniors reside as well that needs to be improved. So I think it's a big societal conversation. It's probably not a single one. It's going to be many different ones coming together because so many people are involved. So absolutely, we've got to do better as a nation.
Yeah, and Dr. Njoo, to be clear for the record, I'm not personally asking, as you say, for a public inquiry. I basically reflected what our Health Minister, Minister Haidu, has said previously about the need after this is all over to have, quote, a national conversation. So exactly as Minister Miller and Dr. Tam have said, the nature and form is to be determined, but I think we can all agree in terms of we need to take care of what needs to be done now. And then afterwards, I think upon reflection, there's different ways we can have that type of conversation in different ways and do better. Thank you. OK. Comme j'ai dit, je pense que c'est vraiment ce qui se passe actuellement avec nos aînés. C'est une tragédie dans des établissements de soins de longue durée. Et comme notre ministre Haidu a déjà constaté, après tout ça, c'est sûr, il faut avoir, comme on dit, une conversation à travers le pays avec toutes les échelles de gouvernement, les secteurs pour discuter comment on peut faire mieux.
And just about masks, Dr. Tam, I'm hoping to find out what you're hearing from your from medical officers of health across the country about the supply of N95 masks, especially at long-term care homes. And if this shipment, this most recent one of 8 million masks that was rejected because they weren't up to that quality, what impact might have that had, and on particular in long-term care homes?
I actually don't have the details on specific impacts on long-term care homes. We do have, daily linkages with all provinces and territories as to what the requirements are. And I do know that there's a sort of distribution framework that is at play, but I'm sure that any shipment that has to be rejected will have some pressure on the health system in terms of its N95 capacity. But I do know that all the requests for assistance that we've received, I think over 40, the majority of them have either been met or are in the process of being met. I don't know the exact numbers. I'm actually very heartened to see some of the domestic supplies being one of the innovations in this space as well. I think some of them are going to be where we're looking at. But yes, I mean, every day, this is one of the biggest, I think, challenges that we feel every single day. All the supplies have sort of being utilized and then stuff coming out is a big sort of process in ensuring that jurisdictions have what they need. But so far as I know, all the requests for assistance that we received have been met.
Thank you, Dr. Ian.
Ian Wood, CTV News. Dr. Tam, some pictures from Vancouver this week show packed beaches full of people again. That province has moved forward with some very gun-ho openings. Yet now in South Korea, a country that's been recognized as having this more under control or getting it under control, is putting restrictions back into place and locking certain businesses down. Do you foresee us having to do that as well?
I think, as you know, the Chief Medical Officer of British Columbia and everywhere else in Canada are being very cautious. Now, the public, having contributed greatly to our efforts, must be reminded that we're not going to be back to completely normal sort of pre-January of this year. And that if there are gatherings of that nature, of course, it's up to us to constantly remind people that that is not the public health advice. I think the advice is to go outdoors, but you got to observe social distancing measures. So it is going to be difficult, I think, because people have heard these messages for a very long time, but we still got to sort of ensure that these habits that may have been instilled continues. So that is still going to be a key part of the response. If there were any uptick in cases, the loosened public health measures may have to be sort of reinstated. We do not want that to actually happen. So I think everybody continues have to listen to their provincial or local public health officers, because this is serious. The virus has not disappeared from the face of the earth. It's still circulating in some parts of Canada. So it is something that is going to have to be a sort of ongoing behavioral shift, which is not an easy thing to do.
And Canadians now are still allowed to travel between cities, between provinces. How is that going to affect reopening? If one area reopens, certain businesses, sectors, recreational facilities, and another doesn't, but people can still travel freely, is domestic travel not a risk to those areas that are reopening?
So this is why you need the national linkages, because you have to share information to know where cases are. But that is true that if there are outbreaks in certain areas, other parts of Canada is going to be looking at whether there's any travel-related cases, so and reevaluate that. And so I think that is absolutely something that we have to watch for in the next phase. In terms of domestic transportation, Transport Canada, for example, has instituted certain measures, including the wearing of masks. Some jurisdictions still have measures in place for anyone traveling outside of their provincial jurisdiction. So they have particular provinces that haven't seen cases or haven't seen transmission, but also if they have a smaller healthcare system or service, they're going to be protecting those areas, including people coming from other parts of Canada through domestic travel. So a number of jurisdictions still have that in place, given their own epidemiologic situation. But that will, again, have to be reviewed as in the coming weeks and months.
Thank you, Doctor. Ceci met fin à la conférence de presse. Merci.